brainstorm. Okay. Dr. Lindo, would you like to read and answer the question later? Yeah.
25-year-old man made with database P 145 85 HTN.
Yeah. And sorry. Can we diagnose hypertension? No. Why not? Give me the reason. Yes, this is the first reading. So what can we do next? Yeah, we can repeat maybe 10 to 10 minutes apart. And the reading should be different in two occasions. So maybe we have to tell the patient to repeat the BP on the next review. And then we can diagnose hypertension. Good. So once we detect the high BP, what can we do? What can we educate the patient? Lifestyle. For example, activity, good. Good. And then lost weight, low salt, right? And then besides smoking, alcohol. Yeah, cut down alcohol, and then lost the weight. Okay, control the weight. Okay, good. So once a patient did above, as we mentioned, and then once we confirm the diagnosis of hypertension, what's the first line medication that we can initiate for this patient?
It depends.
Oh yeah, good point. So because it's a simple scenario, so let me add on. The patient did not have any comorbidity, just hypertension.
What's the race?
Oh, the race, great. Black. Yeah. And what else do you want to know? And the renal function, kidney, renal function, liver function, are all normal. Yeah. So what's the first line medication? Iodine. Good. So when we mention the medication, please include the dosage, frequency, and the dose. Yeah. Would you like to try? Iodine. That's very simple, right? You use every day. Iodine. How many milligrams? Mm-hmm. Yeah, good. Okay. EOD, good, right. So besides iodine, which can be also be the first line? Oblex. Yeah. Yeah, CCB. So name one. Good. Frequency. Yes, it depends. But initially, yeah, we might start from OD and then we will review the patient and increase the dosage. Good. You have a very good basic knowledge. Okay. So for the next review, the patient come back with still high BP. After we initiate the first dosage of iodine, okay, but the BP is still high. Yeah, what can we do? The next step is very important. We add on another medication, and we have to re-educate the patient about the lifestyle modification. So besides that, I think very important thing is that when the doctor prescribes a medication, will the patient take the medication? It depends, right? So we have to make sure. So what we can do is that to make sure the compliance of the patient, okay? To make sure that they know how to take the medication after breakfast and make sure that the patient take the medication every day, right? And to check if there's any side effect, right? Because if patient experience some kind of side effect, like leg edema from the calcium channel blocker, maybe the patient will just hold the medication, right? So we will make sure the compliance of the patient. Okay. So once we initiate the medication, what's our target BD? We have to know our target. So then we will know how many dosage of the medication that we should use. So for the like a simple hypertension patient without comorbidity, yeah, once you need, we all know, we all agree that the BP is high, right? So once we start the medication, what's our target? When the patient reaches the target, we say, oh yeah, you did a good job. We know the answer. That's a previous definition. But now that we revise the target, that should be for the normal person, especially for this young one. Yeah, it should be below 130 over 80. Okay. So now the criteria become more strict. Okay. So the patient come back again, but this time maybe for the third review, the patient has either higher BP, right? What can we do?
still on one track, or is this patient still on one track?
Yes. Yeah. What can you do? Yes. Yeah, we have done that. Yeah. And please repeat the lifestyle modification every time. Yeah. It's better to repeat again and again. And so we have initiated one medication, right? But the BP is still high, even up to 175 over 90. So what can we do in terms of medication? Add another one, yeah, based on thiazide or CCB, right? Okay, yeah, because do you know how much of the BP can we expect to drop by using one medication? You don't know. By using one kind of medication, we can expect systolic pressure drop around 20 and diastolic pressure around 10. Okay, 20 over 10. That's a very practical knowledge for you. Okay? So for this one, so we know our target is below 130, right? And now the BP is 175. So that's 45 in difference, right? So it means that if one medication can cause 20, can drop 20 of the BP in terms of systolic. So it means that we need two medications. Okay? Yeah. Okay, so I hand over to Mrs. Lin for a summary.
Okay, so we have already went through the basic treatment strategy of hypertension. So here's a summary. Okay, so as many of you have already answered, what is the first line treatment? That will be thiazide, calcium channel blockers, ACI, and ARB. And just like some of you have just mentioned, the race difference is also a very important factor for efficacy. And so you should keep it. So it is also very interesting to know that for thiazide and calcium channel blockers, they are especially effective for the Black population. So we can use them in our country. Okay. And in terms of the severity of the disease, we can see that for a milder disease, at the very beginning, you can use just a monotherapy of these first-line agents. But however, just like the last case we have just mentioned, for those who need a more aggressive control on the blood pressure, we may need to use two drugs, the combination. And when you use the combination, we usually use the combination of these first-line agents. Okay. And now we are going to take a more detailed look at each class of these antihypertensive agents. Okay, the first class is the thiazide diuretics, and actually there are many different classes of diuretics. The thiazide and such as the loop diuretics is also another class, and there are also many agents under the thiazide diuretics. And this one, the HCTZ. Okay, I know the name is too long and it's very difficult to pronounce, so we just call it HCTZ. Okay, and anyway, for thiazide diuretics, the mechanism. First of all, yeah, it is a diuretic, so it induces diuresis by inhibiting sodium reabsorption. And however, what's interesting about thiazide is that aside from inducing diuresis, it can also work target at the vascular smooth muscle. So yeah, as you can see, it can also decrease the peripheral vascular resistance. So that's another way how thiazide diuretics can also lower the blood pressure. So this kind of diuretic is preferred for most hypertensive patients without contraindications because it's effective and it will be even more effective if you use the thiazide with in combination with other antihypertensives. And for the dosage, yeah, it's here. Yeah, you guys have answered it right. It's 12.5 to 50 milligram once per day, and we usually use it in the morning. Okay, and however, thiazide is not very potent in inducing diuresis. For patients such as they have the GFR below 30, they might not be very effective for using thiazide. So in such situation, they might need to use loop diuretics instead. And for side effects, you can imagine because this is a diuretic, so it will lead to the loss of electrolytes such as potassium, or sodium, and magnesium. However, what's very interesting here is that in terms of calcium, it actually causes hypercalcemia. This is because thiazides can somehow inhibit the excretion of calcium, so that's why it can retain the calcium. So that would be this side effect would be favorable for patients with osteoporosis. And another side effect is hyperuricemia. So you have to be careful for patients who has gout or a history of gout. And also other side effect includes hyperglycemia and dyslipidemia. And for patients with anuria or renal hepatic dysfunctions are contraindicated. Okay. And thiazide can be used in pregnancy. It has a pregnancy category B. Okay, and the other class of diuretic is loop diuretic. Yeah, it also works by, it lowers the blood pressure by inducing diuresis. It's a very potent, it's a more potent diuretic compared to thiazide. However, it is less effective in lowering blood pressure. Why? Because I have just mentioned thiazide, aside from inducing diuresis, it can also uh, cause vasodilation. However, the diuretics only induce diuresis. So that is the reason why it's less effective in lowering blood pressure. So it's not a very ideal antihypertensive unless the patient really needs diuresis, such as in this situation of severe edema or the GFR below 30 or left ventricular dysfunction. And for the dosages here, usually we use 20 to 80 milligram per day in two divided doses. And for the side effects, they are similar to those of thiazide, except for you can see here for calcium, it calls hypocalcemia. So that's a bit difference. Okay, and for pregnancy, it's not very it's in the pregnancy category C, so it's not a drug of choice for pregnancy. Okay, and another class of drug, also a very important class, is the calcium channel blockers. And there are also many different agents under this class. And however, in our country, just like you know, nifedipine is a very widely used drug in the treatment of hypertension. And for the mechanism, nifedipine is dihydropyridine calcium channel blockers, and this category of calcium channel blockers, they majorly blocks the calcium receptors in the vascular smooth muscles, and they have less effect on cardiac muscles, so they have more effect on peripheral. So what you can see is that it's a potent arterial vasodilator, so that is how it lowers blood pressure. And aside from it can be used to treat to treat hypertension, and aside from that, it can also be used for angina and also tachylysis. Because for tachylysis, you need to relax the muscle as well. Okay, and for the side effects, a very well-known side effect is peripheral edema. It is also related to the vasodilating effect of the drug. And another side effect that worth noticing is that it may also cause reflex sympathetic stimulations, such as the reflex tachycardia or angina associated with the acute drop in blood pressure. Because the reason for this is because nifedipine itself is short acting and it can lower blood pressure very quickly. So um, so that's why it has such side effects. And in order to lower the risk of such side effects, what we can do is to use an extended release dosage form of nifedipine, which means that this kind of dosage form they are specially designed to be slowly releasing the active ingredients in the intestines. So it won't just release the active ingredients right away. And for just the normal dosage form is what I mentioned here, the immediate release one. It can just the very the normal tablets that we see. For these normal tablets, because they release the active ingredient very quickly, so they can also drop the blood pressure very quickly. So for hypertension, if it's possible, we should use extended release nifedipine for the treatment, and the usual dosage is 30 to 90 milligrams per day. Okay, and we have mentioned combination therapy. When we need to use combination therapy, these are some of the combination that shows efficacy, and such as beta blockers and diazide, calcium channel blockers and beta blockers, or calcium channel blockers and diazide. There are many of these therapies are based on diazide or calcium channel blockers. And the advantage of using combination therapy is that it can be more effective, and also at the same time it will produce fewer side effects because you don't have to use a great amount of a single class of agents at a time. Okay, so
So
move on to
here
the
is
next
a
page.
quick question for you. Doctor, would you like to answer? Would you like to read the scenario and give me your answer?
The 45-year-old man has history of stage F, AP, 145, 85. Protection, what is the drug of choice?
What's the keyword for this scenario? Yeah. CHN, congestive heart failure. So what's the drug of choice for BP? What's the yeah? We assume that we already have a confirmed diagnosis, And we already educated the patient about lifestyle modification, but the BP is still high. So which medication from which category should be cyanide? Are you sure? Zero electron. Not the priority. That could be in the combination. Yeah. Especially if the patient has a lymphedema or fluid overflow. But the drug of choice is some medication that we can lower the mortality and morbidity. Is yeah, ACI or ARB. Okay, good. Would you like to answer?
Exactly, our main is HTN,
Yeah. What's the keyword for this scenario? Yeah, I just changed the keyword. Yeah, still the same. So what's your answer? Also still. Pardon? Yeah, ACEI or ARB. Good, good. Yeah, we got the point. So, Mrs. Lee will introduce us about these two medications.
Okay, so now we're going to take a look at the mode of action of ACEI and ARB. Okay, this is the renin-angiotensin-aldosterone system. I believe this is not too unfamiliar for you. And yeah, this system is responsible for the regulation of blood pressure because you see in the glomerulus, there is the cell, the juxtome or glomerular cells that can act like baroreceptors, barosensor. They can sense the blood pressures. So if there is a low blood pressure, it will try to increase the blood pressure. But how does this mechanism increase the blood pressure? Okay, we can see these pictures. The cells around the glomerulus will release renin here. And renin is responsible for the generation of angiotensin 1. And angiotensin 1 has to be converted to angiotensin 2. However, in this conversion process from angiotensin 1 to 2, it needs an enzyme called angiotensin converting enzyme. And you can see ACEI is here. ACEI is an angiotensin converting enzyme inhibitor, so it can inhibit the enzyme. And you can see ARB is here. ARB works by directly inhibit the angiotensin 2. And now you can see what angiotensin will do. Without the inhibition, normally angiotensin will increase the blood pressure by various mechanisms. For example, in the heart, it will increase the contractility, and at a vascular smooth muscle, it will cause vasoconstriction. And at the same time, a very important mechanism is increasing the synthesis of aldosterone. And do you guys know what aldosterone will do? It will reabsorb what? Sodium, yeah, sodium and water. So as a result, the blood volume will increase. So all in all, it will lead to the increase of blood pressure. So yeah, so this picture summarizes how these agents work. And also, other thing you can notice here is that the ACEI not only inhibits the angiotensin converting enzyme, but at the same time, it can also inhibit the degradation of a substance called bradykinin. Bradykinin is an inflammatory substance. Yeah, and ACEI will also inhibits its degradation. So there will be more bradykinin if we give ACEI. Okay, and just like what we have mentioned that ACI and ARB can be used in not only the CHF, chronic, the congestive heart failure, but can also be used in diabetes. And the reason why that it is beneficial for diabetes is also because the ACI and ARB, they have the renal protective effect. And these pictures summarize how this mechanism works. Okay, this is the glomerulus. The one on the left is the normal one. So the blood enters the glomerulus from the afferent arterioles and then exits by the efferent arterioles. And there will be the filtration here. So waters will come out of the glomerulus and goes into the renal tubules. Okay, and this is what will happen during diabetes. During diabetes, the afferent arterial will be dilated. And so when it's dilated, more blood will enter glomerulus. And at the same time, during diabetes, the efferent arterioles, the arterial responsible for exit blood, will be narrowed. So as a result, there will be a lot of pressure inside glomerulus, and therefore leads to the glomerular hypertension and hyperfiltration, and as a result, it will damage the function of glomerulus, and even leads to the symptoms such as proteinuria. Okay, and what ACEI and ARB do is here. An ACEI or ARB, it can dilate. It can dilate the efferent arterioles. So it can, after it dilates, blood can comes out. So the pressure inside the glomerulus can be decreased. So this is how it works to protect the renal function. So many evidence have shown that ACI or ARB is the first line options for patients with hypertension and DM. Okay, so now let's take a closer look at each of the drug. Okay, for ACEI, a very commonly used drug is enalapril, and the dosage is here for your reference. And what I would like to talk more about is the side effects. For ACEI, a very important side effect is angioedema, and actually this side effect is even more common in the black population compared to other races. Yeah. And however, not all the patients will develop such side effect. Usually, the patients with prior histories has the higher risk. And aside from that, dry cough is also a very well-known side effect of ACEI. And just like what I've mentioned, when ACEI inhibits the converting enzyme, it can also inhibit the breakdown of bradykinin. And you know that bradykinin is an inflammatory substance. So the increased level of bradykinin will lead to dry cough. So that is how it happens. And also, ACEI has a side effect of hyperkalemia. This is due to ACEI uh, inhibits the synthesis of aldosterone, because you know aldosterone is responsible for um, reabsorbing sodium, and then at the same time it will also eliminate potassium. So if there is less aldosterone, it will prevent the potassium from elimination. So that's why it may cause hyperkalemia. However, the incidence is only higher for patients with chronic kidney disease. For normal patients, it is fine. And also because ARB has a similar mechanism as ACEI, because you know, ARB also lowers the synthesis of the aldosterone. So we do not combine ACEI with ARB, because if you combine, the first reason is because it's almost exactly the same mechanism. So there's no use to combine them together. And the other reason is that it will increase the side effects such as hyperkalemia. Okay, and another important side effect is acute kidney injury. This is also rare for most patients. However, it will be a big issue for patients with renal artery stenosis or late stage chronic kidney disease. Uh, Actually, the reason is because during renal, what do we say that? The renal artery stenosis, because there will be the narrowing of the renal arteries. So you can imagine if the artery is narrowed and less blood enters the glomerulus. So the pressure, so the blood pressure inside is already relatively low. So if you still give the ACI or ARB to dilate the efferent arterioles, then the pressure inside the glomerulus will be even lower. So that will lead to the ischemia of the glomerulus. So let's see the contraindications. Yeah, so for patients with bilateral renal artery stenosis or volume depletion, they are contraindicated for ACEI because that may lead to acute kidney injury. And for angioedema is also contraindicated, just like what we have mentioned here. And also pregnancy. This one is important. ACEI is absolutely contraindicated in pregnancy. Okay, this is ARB. And I mentioned two agents, losartan and irbesartan. They are quite widely used in our country. And because the mechanism of ARB is similar to that of ACEI, so you can imagine that their side effects are also similar to ACEI, except for several points. The first one is because ARB does not inhibit the degradation of bradykinin, so it does not cause the side effect of dry cough. That's a quite important benefit of ARB. And aside from that, it also has the lower incidence of angioedema, so that is also an advantage. And also remember, do not combine ACI with ARB. And for the contraindications, it's almost the same as ACEI. Okay.
Here is a picture of. Do you know what's this? What's the system? Angioedema, yes. It's I just want to highlight the side effect from ACI or ARB, especially in black population. The patient might complain of this, and this actually happened in the clinic, in my clinic. Have you encountered this kind of patient in your own clinic? Yes, yes, some of you have this experience. And so we just want to highlight of this. And the best strategy to do this is to just shift to another medication. Okay. So here's another quick quiz for you. Anyone want to try? Would you like to try? Can you see? Yeah.
What's the 5-year-old name? It's filled with skinny disease. PP 145
And what's a drug of choice? What's a keyword? Ischemic heart disease. Yes. So what's a priority that we should initiate? Beta blocker. Yeah. Although we can also combine CER and ARB for this kind of patient, but the drug of choice is beta blocker. Okay, good. Good answer.
Okay, so let's move on to see beta blockers in details. And there are also many beta blockers. And here I just introduced the two anti-blockers, atenolol and propranolol, because they are more commonly used in the country. Okay, and as you guys remember, the first line treatment, the first line agents for hypertension does not include beta blockers. So because beta blocker is not a very appropriate agent for first line treatment, except for a patient has other comorbidities such as the ischemic heart disease. In that situation, we may use beta blockers as a first line agent. And also another situation that we will use beta blocker is to use it in combination with other first-line agents. Okay, and and also another important concept is that when we choose the beta blockers to treat hypertension, the cardioselective one, the cardioselective beta blockers such as atenolol, they are preferred over the non-selective agents. The cardioselective means that they primarily target at yeah the cardiovascular system. Yeah, and for the non-selective ones, they may be also act on different part of the body. For example, for patients with asthma, it will be quite. You have to be very cautious when you use beta blockers, or even avoid using beta blockers, because remember there are also beta receptors. The beta receptors on the bronchial smooth muscles. So if you block the receptors on the bronchial smooth muscle, what will happen is that the patient will have the bronchial constriction. So that will be very dangerous. And even for patients with diabetes, because the adrenergic receptors are also responsible for functions related to insulin resistance and insulin secretion. So for patients with diabetes, will also be not safe if you choose the non-selective ones. Okay, so for the dosage of atenolol and of propranolol is here for your reference. And what I would like to add here is that for atenolol, you will have to adjust the dose according to the renal function. The reason is because atenolol is eliminated by the kidney. So if a patient has renal dysfunction, then you have to lower the dose. And here is that usually we lower the maximal dose we give to the patient. And for propranolol, because this one is not that much eliminated by the kidney, it is metabolized by the liver. So you don't have to adjust your dose if a patient has renal dysfunction. Okay, and for the contraindications, beta blockers, the atenolol and propranolol is contraindicated for pregnancy, but not all the beta blockers are contraindicated for pregnancy. There are still some beta blocker can be used in pregnancy, which we will mention it later. And for asthma, severe asthma is contraindicated, and also for heart block, second to and third degree of heart block is contraindicated, and also the acute left ventricular dysfunction exacerbation is also contraindicated. And for the symptoms, it may lead to weakness, bradycardia, and it may also mask the symptoms of hypoglycemia in diabetes. And okay, for your and other side effects, just for your reference. Okay, so this is a summary. This is a summary about how do we give a specific class of antihypertensive agents according to the comorbidities of a hypertensive patient. We have mentioned I know the words are the characters are quite small here. Okay, for patients with heart failures and diabetes, and also the chronic kidney disease, not the late stage, but just the milder chronic kidney disease, ACI or ARB is preferred. And for patients with stable ischemic heart disease, we may give beta blockers as first line, and also for a patient with for secondary stroke prevention, we can give thiazide. Okay.
So here is another scenario. Dr. Puji, would you like to read the scenario and then answer?
35-year-old pregnant woman has BP of 145/90, a 12-week what BP medications can be initiated. Yeah, what's the gestation age?
Maybe after 10. We confirm the diagnosis of hypertension. Yeah. So we focus on more on the medication. What's your prescription? Yeah, and including levodopa, and including the dosage, frequency, and the rate. Yeah, a little bit, 500 PO and 88 every 8 hours. Maybe a little bit high, but still okay. Yeah, you have to monitor the BP intensity. So besides mesodopa, what else? What else can we give? Yeah, three medication for kind of the high BP in pregnancy. Can you remember? Lobetalol, right? Nifedipine, good. So for lobetalol, the dosage. Yeah, good. Awesome. So what's the dosage for lobetalol? And what's the dosage for nifedipine? 20, and the frequency or OD. Okay, good. So here's a table.
Here's a table that summarizes the first line treatments for chronic hypertension in pregnancy. And you guys are very smart. You have answered them right. Yeah, the first line drugs include methyldopa, labetalol, and nifedipine. And usually, like the long-acting nifedipine is preferred. Okay, and now let's see the mode of action. Does anyone know what's the mode of action of methyldopa? Anyone?
Anyone can answer. That's different from the medication we mentioned above. Quite easy, isn't it? Mocha? Do you remember? No, none of you?
Just to give you a hint, it is also related to adrenergic receptor. Also related to adrenergic receptor, but different from what we have.
Beta blocker, calcium channel blocker, ACE, another alpha. Speak out loud. Alpha what? Alpha blocker?
Okay, yes. It's an alpha blocker, but to be more accurate, it's alpha 2 receptor blocker. Yeah, sorry, agonist. Sorry. Yeah, alpha 2 receptor agonist. Yeah, because alpha 2 receptor is for the inhibitory effect. Yeah, and so it will inhibit the release. The stimulation of this alpha 2 receptor will inhibit the release of the neurotransmitters such as norepinephrine. So that's how it lowers blood pressure. Okay, and for labetalol, what's the mechanism? What's the mode of action? Labetalol.
It's easy according to the ending. LOL. Beta blocker.
Yes, beta blocker. It's a I said it beta again antagonist. Yeah, it's also beta blockers, and it also has some alpha blocker, alpha antagonist activity. But altogether, it will they will lower the blood pressure. And how about amphetamine? Yeah, it's calcium channel blockers. You guys already know. Okay, and among these three, the methyl-dopa is usually the drug of choice because it has a lot of long-term data that supports its safety. It's an old drug and also has a lot of evidence supporting its safety. So usually we give methyl-dopa for pregnant women with hypertension. And however, nowadays we also use labetalol, and we even use we're using labetalol more and more often because it has fewer side effects compared to methyl dopa. Yeah, even though methyl dopa is safe for pregnancy, however, the downside of methyl dopa is that it has many side effects. Okay, so now we'll take a closer look at methyl dopa. Yeah, it's a centrally acting alpha-2 agonist, and this is how it works. It will stimulate the alpha-2 adrenergic receptors in the brain so that it will reduce the sympathetic outflow from the central nervous systems, and at last, it will reduce the overall sympathetic tone. And this is a drug of choice for pregnancy. However, it has limited use for the routine management of hypertension because it has too many side effects. You can see here. Okay. Okay. First of all, the sodium water retention is a very undesirable side effect of methyl dopa. And also, methyl dopa has the anticholinergic effect, so it will cause sedation, symptoms such as sedation and dry mouth. And also, methyl dopa has the higher incidence of orthostatic hypotension compared to other antihypertensive agents. And also, methyl dopa will cause the rebound hypertension if we abruptly discontinue the medications. And aside from that, methyl dopa also leads to liver toxicity. So patients with active hepatic disease are contraindicated for using methyl dopa. And also another side effect is hemolytic anemia. This is a type of anemia that is related to the generation of autoimmune antibodies inside the body because your body produce the antibodies that can target against red blood cells. So it will lead to hemolytic anemia. And others include postpartum depression and sexual dysfunctions. So this is the most important one. Patients with active hepatic disease is contraindicated. Okay, next case.
Okay, so here's a review question. Which category of medication is absolutely contraindicated in pregnancy? Yeah, good. Okay. So let's move on to the next topic. Our second topic is diabetes. Okay, and let's review the mechanism of all DM medication.
Okay, so this picture summarizes the etiology as well as the site of action of the DM medications. As you can see, there are many etiologies that may cause hyperglycemia, such as decreased insulin secretion, and also the insulin resistance, such as the insulin resistance in the fat tissues, and in the muscle, and also in the liver. Yeah, in the fat tissues, the adipocyte resistance to insulin will cause the increased lipolysis, and that will produce a lot of toxic metabolites. And in the muscle, the insulin resistance will decrease the glucose uptake, and in the liver, the insulin resistance will increase the hepatic glucose production, will lead to increased hepatic glucose production. And aside from that, another mechanism is that there will be the impaired GLP-1 secretion, and GLP-1 is an incretin. Incretin is a peptide released by the intestine in response to food intake. So after you take food, it will release this kind of substance. And what GLP-1 do is that the incretin can stimulate insulin release and also inhibit the glucagon release. So it's also a very important factors. And also in the kidney, there will be increased glucose reabsorption during DM. So that is also a reason of the hyperglycemia. And okay, this is the mechanism. And now you can see how does each class of the drug works. Like metformin, metformin is here. That is, it's make it MET in short. Okay, metformin can decrease the hepatic glucose production, and TZD are here, liver, muscle, and also the fat tissue, and the TZD can increase the insulin resistance, and sulfonylurea is here. It can enhance the insulin secretion. And aside from we also have the newer agents such as the GLP-1 analog. They look like GLP-1 and they can act like GLP-1. And what GLP-1 do I already mentioned over here. And there's another new class of agents called DPP-4 inhibitors, and also the SGLT2 inhibitors. These two agents are not very common in our country. I don't know if we have these agents or not today, but these agents are very popular on the global market, and are very widely used in the developed countries because aside from lowering blood pressures, they also have other benefits such as the cardiovascular benefits and also some protective benefits. The SGLT2 inhibitor has the renal protective properties, and it can also help to lose weight. Okay, next slide.
So here is a scenario. Doctor, would you like to try? What's the first line medication for this patient? And you read.
A 58-year-old of screening fasting blood sugar of 11 millimoles per liter, hemoglobin A1C is 8.5, normal kidney function. What is the first line medication for him?
Can we diagnose diabetics according to so what's the criteria for diabetics? The fasting sugar should be more than 7, and the postprandial sugar more than 11.1, and the HbA1c 6.5. Yeah, right. So we can diagnose diabetes. So what's the first line medication? Metformin is good.
Okay, so this is a general treatment strategy for type 2 DM. For the medication, the first line is metformin. This is a drug of choice for type 2 DM. For patients without any contraindications, you should use metformin first. Because metformin has a high efficacy and it also has a low hypoglycemic risk, and it also has a neutral effect on weight, which means that it will not make you to gain weight. And it also has potential benefits on CV risk, and also it's not expensive. However, if a patient cannot be well controlled by metformin, then we have to step up our therapy. What we will have to do is to add on. Aside from metformin, we also have to use other agents such as sulfonylureas, TZD, or even insulins or other newer oral agents. Okay, and however, for any patients, no matter is on the metformin therapy or already on the combination therapy, if the if the HbA1c is too high or has the symptomatic hyperglycemia, then we have to add on insulin right away. And also a very important concept is that because there will be a persistent decline in the beta cell function as the disease progresses. So a patient may need to change to use different class of agents if he or she cannot be well controlled by a certain class of agents. So you have to know about each class of agents first. Okay, and the first drug is metformin. The mechanism, the major mechanism is that it can decrease the hepatic glucose production. And also, aside from that, it can also increase the insulin sensitivity in the cells, in the muscles, and it has no direct effects on beta cells. And for the side effects, one of the most well-known side effects is diarrhea or GI discomfort, and also vitamin B12 insufficiency is the side effect. And another very important one is lactic acidosis. This one is rare for most patients. However, the risk will increase in patients with renal insufficiencies or CHF, hepatic impairments, or excessive alcohol intake. And yes, because for metformin, okay, the dosage is here. Usually we give, usually at the very beginning we give 500 milligrams per day, once per day, or twice per day, or 850 milligrams once per day. Okay, and I know we have to adjust the dose if the patient uh, has the renal dysfunctions, because metformin is eliminated by the kidney. So I try to make a small picture over here. Okay, for patients whose eGFR is below 30, it's contraindicated for using metformin. So patients with severe renal dysfunction is contraindicated. And for patients who has the eGFR between 30 and 45, if a patient is already on the metformin therapy, then he can continue to use it, but have to monitor the renal function closely. However, if a patient has not been using the therapy, then we do not initiate the therapy for such patients. And for the pregnancy, yeah, metformin can be used for pregnant women. The pregnancy category is B. Okay.
So here is a scenario. 55-year-old visits a female and with diabetes diagnosis, and she was on metformin 500 milligram BD and glycolide 40 OD, and unfortunately she experienced several episodes of hypoglycemia. So as a doctor in casualty, what should we do next? Glyphosate. Yes. Why? Reduce the dosage of glyphosate. Yes. It has more side effect than metformin, right? That's a very important concept.
Okay, so now we are going to take a closer look at sulfonylureas. And sulfonylureas they have the members such as glibenclamide and glycoside. They are all sulfonylureas. And actually, all the sulfonylureas are equally effective. They are but they are different in their pharmacokinetic profile. For example, for some sulfonylureas, they are majorly eliminated by the kidney, and some is metabolized by the liver. For example, we can see that glibenclamide and glycoside. Yeah, the dosage is here for your reference, and you can see that for glibenclamide, you will have to reduce the dose, reduce the starting dose, or consider other alternatives if a patient is renal insufficient. And however, for glycoside, because it's not that much eliminated by the kidney, so it's preferred for patients with renal insufficiency. Okay, and okay, for the mechanism, yeah, the mechanism of sulfonylurea is to increase the insulin secretion. And for the side effects, the most common one is hypoglycemia. So we should be used with caution for if we give sulfonylureas to elderlies. And aside from that, sulfonylureas may also cause weight gain. So that is also a very undesirable side effect of sulfonylureas. And it is not very safe for pregnant women. Okay.
Okay, so here's the next scenario. Dr. Mamba, would you like to try?
Yeah, this is the criteria of
The Mamba.
female with congestive heart failure and length, fasting blood sugar of 11 milligrams per liter, HbA1c, and normal kidney function. Each oral antidiabetic agent should be avoided.
Yeah, it's a review question. Sulfonylureas, especially glucosamine, and if there's a severe renal dysfunction, then we should avoid metformin as well. So what should we use instead? Insulin. Yeah. So besides insulin, there is another oral agent that might be available here in this country as a TZD. Okay.
Okay, so TZD. Okay, TZD is sometimes being used as a alternative of sulfonylureas, and the mechanism is also different from sulfonylureas and metformin. Okay, you can see here it can increase insulin sensitivities at muscles, liver, and fat tissues. And for TZD, I think the most famous one is the side effects. The weight gain, it may cause food retention, which will further lead to weight gain and peripheral edema. Okay, so for patients with edema should be aware, should be very cautious when using TZD or should avoid using them. And such side effect is even more common when the patient is also using insulin therapy at the same time. And okay, and for the same reason, congestive, it may also cause congestive heart failures. So and also TZD, the dosage of TZD is here. The pioglitazone and rosiglitazone are some of the very widely used TZD, but I don't know if we have them in our country or not. Okay, and TZD is metabolized by the liver. It's not eliminated by the kidney, so it could be used in patients with renal insufficiency. However, it is contraindicated for patients with hepatic impairment and also heart failure. This is related to the fluid retention side effects. Okay, and another interesting properties about TZD is that it usually has slow onset. It may usually take several months, like at least up to 3 months, to reach its maximal efficacy. So we have to wait for the efficacy to come out. And some of the TZD may increase the risk of MI, such as this agent, the rosiglitazone. However, some of the agents, such as pioglitazone, can decrease the triacylglyceride level and increase the HDL levels, which is quite good advantage of using this agent. Okay.
Okay. So who would like to try this? Okay. Would you like to try?
A 65-year-old female and pro-control and oral fasting blood sugar, proximity HbA1c, and detective function. Is oral
Awesome. Yeah. Which sorry, that's a redundant. Yeah. The yes, metformin and the glucosamine. some kind of material. Let's skip it. Okay, and let's go on to for the insulin. Okay. For the HbA1c, if it is above 10%, then it's a time for us to initiate insulin.
Okay, so before we go to take a closer look at how to give insulin, we can now come to see this is the pattern, the pattern of the plasma glucose level and the plasma insulin level in our body after we eat each meal. And this is the time table. Okay, you can see that after the food intake, when there is the increase of the glucose, the amount of insulin in the plasma will also increase. So if a patient is not able to is not able to utilize insulin, and when the patient need to need us to give them insulin, what insulin regimen do is try to mimic the pattern, the already existing insulin patterns in our body. As you can see, we may combine the long-acting insulin together with the short-acting insulin in order to mimic the pattern. You can see if long-acting insulin okay, it's here in green line. It can provide, it can help to maintain the insulin levels between meals to keep a very steady amount of insulin levels throughout the day. And before each meal, we can give the prandial insulin. Okay, this stands for breakfast, lunch, and supper, and this is bedtime. Okay, we give prandial insulin. So this prandial insulin is capable of covering the glucose we intake in each meals. Okay, this is the ideal situation. And this is also another way of giving insulin. But in this situation, the basal insulin we use has a shorter duration. So you can see the duration is shorter and it will produce a small peak here. But anyway, the concept is still the same. We combine a longer acting one with the shorter acting one to cover the glucose we intake in each meal. Okay, these are the agents that we are using in our country now. Okay, they are the octropid. Now these are brand name at the top. These are the brand names. The octropid is the active ingredient is the human insulin, and this one is short acting. And so the short acting insulin can be used. It's very good for to be used as a prandial insulin to use it before meal. And we also have the longer acting insulin. It's this one, protophane. Protophane, the active ingredient of protophane is insulin isophane, or also known as NPH. And because it has longer duration of actions, and so it is suitable to be used as basal insulin. And aside from these two, we also have the mixture, this one, the octropane. This is the brand name. And for the active ingredient, this one is the combination of the short-acting insulin, the human insulin plus insulin isophane. And I know under this brand name, they actually have the mixture of these agents with different proportions, like 30 to 70, or 40 to 60, or 50 to 50. But anyway, this is a mixture of the short acting and the longer acting one. Well, in our country, we don't have the very long acting basal insulin. Currently, we only have this one, the intermediate acting one. But anyway, we can still use this one for basal insulin. Okay, so for insulin, just to give you some reminders, insulin, some of the a part of insulin is eliminated by the kidney. Not all, but some part of it is eliminated by the kidney. So you still have to lower the dosage for patients with more severe renal dysfunctions. Okay, and for side effects, insulin will cause hypoglycemia, and this is the most common side effect. So that is also the reason why we have to monitor very closely after we give insulins, because the blood glucose monitoring data is always very important very important tool for us to decide to adjust the dose, the appropriate dose for patients. And also insulin also cause weight gains. And the others include injection site reactions. And insulin is the drug of choice in pregnancy. Actually, insulin is the safest drug for diabetic pregnant women, and metformin is the second. Okay, and for administration, yeah, it's a parenteral form, so it's in a parenteral dosage form, so it may usually cause some difficulty for patients to handle the needles by themselves. So if possible, the pen devices, which means the insulin injection is designed into a dosage form of pens, and it will be easier for them to handle. And it will also help to improve the accuracy. However, I think the pen device is not very common in our country now, but if possible, you can prescribe it to improve the convenience. Okay. Okay, and so now we have to talk about the dosage. So if a patient come, oh, how will you start? How much dose will you have to give at the very beginning for a patient who want to use insulin? This is empiric method. Um, at the very beginning, for the basal insulin, we can start with 0.1 units per kg for patients. And for the prandial insulin, we can also start with 0.1 unit per kilogram and before each meal. So before each meal, we give 0.1 unit per kilogram of the prandial insulin, the shorter acting insulin. And for the basal insulin, you have to give in the form of the intermediate acting or even longer acting insulin. Okay, so I already show the answers. Okay, this is, for example, now let's come to the problem over here. Okay, for example, if there's a patient who weighs 80 kilograms, then how much insulin, basal insulin, do we have to give? Okay, for 80 kilograms of weight times 0.1, so we will give 8 units of insulin, the the long-acting insulin for the patient as basal insulin. And for the prandial insulin, we can also use this formula. Okay, so 80 times 0.1, so that will equals to 8 units before each meal. So for each meal, before each meal, we will get 8 units of insulin. And what kind of insulin? Because it's prandial insulin, so we give the short-acting insulin, okay, before each meal. Okay, this is just at the very beginning to give you a concept of how to start the therapy. However, the most important thing is that you always have to evaluate based on the self-monitoring blood glucose level, and adjust the dosage over time. So the glucose monitoring data is very important. Okay, and so if one day we really need to adjust the dose, how do we adjust? How do we know how much insulin do we have to add if a patient, if the current therapy is not enough for the patient? Here is a very simple estimation method. The formula is here. You can just remember 1 unit of insulin can decrease 1.5 millimole per liter of the blood sugar. And this table is just to give you a quick reference for calculation. Okay. So do you guys still remember the goal of the goal of therapy? What is the goal of therapy for prandial glucose?
Like for
Fasting glucose.
what's the goal for our treatment? We know the criteria of diabetics, right? But once we initiate the treatment, what's our goal? It's the same for fasting glucose, below 7. Okay? So for the postprandial, what's our goal? The criteria for diagnosis diabetes is more than 11.1, right? But our goal is below 10, okay? And the HbA1c. The criteria for diagnosis is 6.5, and for our goal is below 7. Right? If that's for a younger patient, we can keep it below 6.5. But in general, this is a goal. So that's why if we have a blood glucose between 4 and 7, that means normal, so we won't increase our dosage of insulin. But if it is above 7, then we can add on 1 unit of insulin on the existing insulin. Okay, you all get it?
Okay, so remember this one. The 1 unit of insulin can decrease 1.5 millimole per liter of the blood glucose.
Remember this, and then on the next slide we will practice.
Okay, so here we have to do a practice. Okay, the example states here. Actually, this is quite a simple situation. It says that suppose there's a patient that use 30 units of insulin glargine. Okay, insulin glargine is a long-acting insulin, so which means that he uses 30 units of basal insulin at bedtime. Okay, the basal insulin is 30, and he uses 12 units of rapid acting insulins before each meal. So if now the problem is coming, so now if his prandial blood glucose concentration are as high as 11 mole per liter, and the goal, remember we said is 7 for the fasting glucose. So 11 and 7. 11 is 4 away from 7. So how much insulin do we have to add?
Anyone want to answer? That's for 2 point. Yes, approximately. But usually we will add that number, right? Maybe 2 or 3. So here's the answer. Maybe we will increase the compendial dosage from 12 to 14 or 15. It depends. If we want to act more conservatively, we will take only add 2. If we want to act more aggressively, we will add 3. Yeah, that's a very practical calculation. So thank you for your participation. Do you have any questions for today's lecture? So far, no. So for the next week, yeah, Dr. O want to make a
reputation and ACI. So ACIs are actually tolerated in the first trimester, but not in the second and third. And why? So I think you have to know why it is contraindicated in pregnancy before you understand the logic. Does anyone know why it is contraindicated in pregnancy? Okay, it's to do with the equilibrium. It decreases the amniotic fluid. So from the fetus. So when does the fetus start making urine? electrical device. Second and third trimester. Because the first trimester the patient doesn't start producing from maternal. So that is the reason why it's pregnancy in the second and third trimester. But if it was just the pregnancy, then you would select that as well.
Thank you, Dr. Lau. Any other questions? No. Okay, for the next week, we are going to have the Intern Conference with Professor Park. And please come here on time. And thank you for your participation for today. And if you don't have any questions, see you next week. And have you exactly serve your break now. Thank you. Welcome.